Good morning. Thank you for joining us. This is the Alzheimer's Disease and Related Conditions Advisory Committee, or ADRCAC. That's the acronym we'll be using today. Today is February 5th, 2026, and 10 o'clock. This meeting runs till 1. Thank you for joining us in this virtual as well as in-person place. Let's go to the next slide. I am Carol DeAndres. I am the manager of stakeholder engagement for the Master Plan for Aging, or MPA, at the California Department of Aging, or CDA. Let's go to the next slide. You have a few options for joining us. So apparently it worked. So thank you for being here with us today. Next slide. We have our accessibility. We have American Sign Language. Thank you to Heather and her partner. We have closed captioning. That is also available to you. If you go to the bottom of your Zoom toolbar, you should see a CC, closed captioning. And if it's not there, check under that More button. Zoom likes to do updates and hide things. And you will have the opportunity to show captions. Next slide. So this is for our guests that are in person today at the California Department of Aging here in Sacramento. In the event of an evacuation order, please evacuate the building immediately. You have CDA staff with you today in the room, and they can help guide you to the nearest stairwell, and they will help guide you to our relocation site, which happens to be 2890 Gateway Oaks. So if there's any other information, it will be shared with you, but we just want to make sure that you are a guest and everyone remains safe. Next slide. So we have some virtual meeting operations. The chat function is enabled for committee members, California Department of Aging staff, other state staff and guests to share out meeting-related information with our attendees today. And we invite our public attendees, if they would like to provide public comments during the public comment period, which I believe is around 12:30 per the agenda. There is the question and answer function is also enabled for the committee to respond to questions. Do know that if time runs out and they're unable to get to your questions, we will make sure to get back to you. And at any time, please feel free to email the Engage email box, which is monitored all through the business day. Engage, ENGAGE, @aging.ca.gov. Just some reminders about our public comment period. For in-person comments, any folks attending in our room today, raise your hand and a staff person will call on you. For comments from our virtual attendees, you have a raised hand icon on your Zoom toolbar. Feel free to use that. If you are appearing or attending this meeting by phone, you have a *9, which will also indicate a raised hand, and we will unmute your line. Do note comments are no longer than 2 minutes so that we can ensure everyone has an opportunity to comment. And again, at any time, feel free to send your written comments to our Engage email box at engage, ENGAGE.ca.gov. And I would like to turn it over to our committee chair, Dr. Canio. Good morning, Dr. Canio.
Good morning. Thank you so much, Carol. I'd like to officially call this meeting to order. And welcome to the Alzheimer's Disease and Related Conditions Advisory Committee, the mouthful, ADRCAC meeting We're glad to have you all here with us. Before we begin, I want to remind everyone that this meeting is being conducted in accordance with Bagley-Keene Open Meeting Act, which requires that our discussions and decision-making remain transparent and open to the public. If you are a committee member, please turn on your cameras so that we have a clear visual record of attendance and participation. We'll now take roll call to confirm who is present. If you could please have the names of the members on the screen, please. All right, so that's me, behavioral health representative, and Carlos.
Here.
Great. Assembly member Gail Pellerin. We have a representative for Assembly member Gail Pellerin. Okay. Senator Jesse Reagan. I'm trying people's names, sorry. Sally Bergman.
Present.
Great. Claire Day. She's not here. Dr. Thompson. Yep. Go ahead and move to the next slide. Barbara.
Here.
Dr. Mobley.
Here.
Dr. Kazi.
Here.
Celine Regalia.
Here.
Julie Slurry. I saw her. Okay. Dr. Farias.
Here.
Great. Great. Well, we are excited to welcome the new members of our committee. So we have now Stephanie, Jerry, Janine, and Kathleen. We would like you to briefly introduce yourself and tell us what inspired you to be with us in this committee. So I'll call on, I guess we will go by what we're seeing on the screen first. Janine?
Sorry, I had to hit the unmute button. Hi, I'm Jeannie Walter, Miss Surly. I am representing families related to this. My dad, both his brothers, my grandmother, her sister all had FTD and ALS. I'm a primary care physician and I've worked at Kaiser for a while, since 2008. And I'm now working in the memory care center there at Kaiser. So I guess I was inspired to do this because I think I can bring a unique perspective given the many different hats that I've worn, and just hope I can help make a difference.
Thank you so much for joining us. Jerry?
Hi, good morning. I'm Jerry Jew. I'm a family medicine doctor by training, and I'm the Chief Strategy Officer for Northeast Medical Services, a FQHC here in the local Bay Area. What inspired me to join this esteemed committee is that I think a lot of patients suffer from dementia, Alzheimer's, and related diseases, and it's especially in the Asian population where it's not really addressed well. Maybe it's the stigma, maybe it's that probably expectations of caregivers, sons and daughters or grandkids helping the patient, but it's just really not the proper education and the right allocation of resources to this problem. I think the FQs serve an important role in this disease management and solution, as FQHCs and community clinics are probably serve 1 in 7 Americans. So it's bringing that kind of perspective into trying to solutions. Thank you.
Thank you so much. Kate?
Hello. My name is Kate Schoenberg.
Sorry,
That's okay.
there you go.
Okay.
Okay, now go.
Yeah, you're good.
I'm good.
Yeah.
I am very excited to be a part of this commission. I have had several family members that have had Alzheimer's, and it varies from my husband to my stepfather to my father. And witnessing what the people around my loved ones affected me the most, because it's so hard to understand the disease, and many people don't. And so I'm here because it's important to me to help those people who help, because it is tough, and it's hard to keep your memory of that person. And so I look forward to being able to participate.
Thank you so much, Kate. Stephanie?
Good morning. This advisory commission really interested me because the majority of my time as a social worker and program manager has been with Aging and Veteran Services. And so the programs that I've worked in, we have seen a major increase with Alzheimer's and dementia. And, it affects the caregivers, the families, everyone. And also my 93-year-old grandmother has dementia. So it hits close to home. So I was very happy and honored to, be able to apply for this and to be a part of it.
Thank you again for sharing your reason why you're here with us. I'm sure we will be able to get more perspective from everyone with the different backgrounds that you've shared. To learn more about our new members and existing members alike, please go to the committee membership bios. And I think one of our team will put that on the chat here on the ADRCAC webpage. I'm still going at the wrong name, sorry. All right. So we can move to the next slide. So as far as for our committee, we are still looking for other members. The California Health and Human Services, with support from the California Department of Aging, is still seeking to fill up 2 seats on the Alzheimer's Disease and Related Conditions Advisory Committee with individuals who have personal experience living with Alzheimer's disease or related conditions. There are different types of dementia, as you just heard from our new members, whether it's Lewy body, frontotemporal. We need everyone's voice to be present, especially in this committee. So we're seeking representatives whose authentic representation and unique perspectives as persons living with Alzheimer's or related condition enhance the community's expertise through meaningful engagement and dialogue. So if you know anyone interested in joining this advisory committee and offering their knowledge, expertise, and leadership, please encourage them to apply to the committee via the ADRCAC Lived Experience application link that we'll place into the chat, or they can email engage@aging.ca.gov and request the link to the consumer application. And thank you to those who have already sent a few recommendations. So, but I would encourage everyone, if you know anyone, please let them know about this exciting opportunity to serve with us. So with that, we can go to the next one. So we'll move to the approval of the November meeting minutes. Hopefully everyone had a chance to review. Do I have a motion to approve the minutes as presented or shared via email?
I move.
So moved.
Second.
Great. All those in favor, please say aye.
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 I think there might be some abstainers. There should be. All right. Okay, the motion carries. The November meeting minutes are approved. All right, so up next, I have the pleasure of, well, before that, any questions right now? Anything you'd like to share? Good. So now I have the pleasure of introducing Susan Damaris, Director of the California Department of Aging, joining today's meeting to provide us with some important updates. Thank you. She's here with us.
All right. Any echo?
Okay. Can the people at online hear me all right?
I can.
Okay.
Sounds good, Susan.
Okay, good morning, everyone. I'm here in the room at CDA and I have the best view in the house. I am looking at our chair and vice chair, Wynn and Carlos, and I want to start, I mean, they're just in full view. I want to thank you both for leading this advisory committee, for the work that you put in between meetings, and for helping us to recruit these outstanding new members that were introduced today and who are joining us. Kate's here in the room. Kate, a very warm welcome to you. Also, Stephanie, Jerry, and Janine, welcome to you. We had an amazing response to our recruitment. I think we've never had more applicants, and it was very difficult to choose, but you, the four of you that are joining today really stood out because of your personal commitment, your professional qualifications, your work history, and the geography that you represent. So welcome. We need you here. You're wanted, and we want to hear from you. So starting today, don't hold back in your first meeting. Please speak up. We need your voices. You were invited for a reason, and don't forget that. I'm excited to share, and I also want to thank our staff. When we're virtual, I don't always get to do that because I don't see them. But Brian, who you met at the last meeting, who's formally staffing this committee, Anna, Callie, Sarah Steenhausen, who leads the team, and Julie Solier from the California Health and Human Services Agency is on. She was, her audio wasn't working, but a special thanks to Julie, who works with Secretary Johnson and is very active and involved in this committee behind the scenes. So just a couple announcements from me today because I'm really excited to jump into the agenda. Last week, we released the 5th annual report to the legislature on California's Master Plan for Aging. You'll be hearing more about that, but we're very excited. Similar to when the master plan was first released 5 years ago, it was launched on January 6th, and there was a lot of media attention on that day in 2021 about activities at the US Capitol. And we thought, oh my gosh, there goes our shot. You know, we're going to be overshadowed. And that was not the case 5 years ago. And even in these days and times, it is a testament to all of you. It is a testament to this administration, Governor Newsom's administration, to the legislature and stakeholders across the state that we're going strong in our 5th year, and there's lots to report in our annual report that we've not, you know, we continue to keep our focus on what matters most, which is the title of this year's plan. And what really matters most is hearing from the community, hearing from people with lived experience, hearing from stakeholders. And this is one of the ways that we do that. So you'll hear more from Sarah about the annual report. Is that right?
Actually, no, I'm doing aging and disability lived experience advice.
Oh, okay. So you won't be hearing much more, but you'll see the link in the chat. You'll get to see a year's worth of progress being made on our 10-year blueprint for our state. We're at the midpoint. We're really excited to be evaluating the plan this year at the midpoint. And that's something we're excited to share with candidates for governor to help renew interest and momentum in the plan as we change administrations next year. I also wanted to touch briefly on the January 10th budget, the governor's proposed budget that was released January 10th, and to walk you through that process. California is on a July 1 through June 30 fiscal year, and we need to have an approved budget by the middle of June by the legislature and signed into law by the governor. So the January 10th budget is the first step in a very long and winding road that leads to a final approved budget. So the governor has proposed in the January 10th budget a number of cuts that will now be heard in the budget committees by the Assembly and the Senate, and there will be ample opportunity for stakeholders to weigh in on the proposed cuts and changes. We find our state to be in a deficit situation, and it's the result of some confounding factors, including anticipation of HR 1 and the impacts of House Resolution 1 on our state Medicaid program, changes in SNAP or nutrition programs, and adjustments that are being made at the federal level, among other factors. So things will continue to change this winter, this spring, as the legislature meets and deliberates on the budget. And we will talk more about it at the next meeting when things are more concrete by the next meeting of this group. I wanted to end with a couple of opportunities that are on the near horizon. So while we are in a deficit situation, while there are cuts proposed to programs across the board, there are two funding opportunities that we're very excited about. The first is Proposition 1 in the Behavioral Health Services Act. So there's significant investment in behavioral health services, a very important topic for this committee, a longstanding topic. Barbara McClendon is in my view on my screen right now. Barbara's been a huge advocate and champion for meeting the behavioral health needs of people living with Alzheimer's, dementia, as well as family caregivers. And there are opportunities at the county level. Every county in California has to submit and has submitted for approval their intended plan for how they're going to cover their local jurisdiction with these Behavioral Health Services Act funding. We also anticipate late this winter, early spring, the California Department of Public Health to release a funding opportunity, a statewide opportunity for population-based prevention strategies that includes older adults, people with disabilities, family caregivers. So that's a competitive opportunity, we believe, that will be coming soon, and we'll make sure you all learn about that. Our sister department, the Healthcare Access and Information Department, HCI, is working on the behavioral health services workforce, and we'll be learning more and seeing more from them this spring. And then the Behavioral Health, the Commission on Behavioral Health also will be announcing an innovation fund that will have opportunities for organizations to compete for dollars there. Additionally, we were approved as a state by the federal government for our Rural Health Transformation Grant, and we're finalizing language on that grant now, and so you'll be hearing and learning more about the opportunities in our rural communities to invest in healthcare, which includes, of course, older adults, people living with Alzheimer's and dementia. So more to come on the rural health transformation also. So we'll be busy this spring. CDA is committed to making sure you hear about these things as they occur, and I hope everyone subscribes to our Engage. I think at the end of the meeting, we'll make sure you're a subscriber, because that's where we get these announcements out in real time. So I'll end there and turn it back to Wynn.
Hey, thank you so much, Susan, for the updates and your continued leadership and engagement and dedication. With that, we will now move to our next set of presentation. It's my pleasure to introduce our first presenters. We have the screen. So we are honored and today to have Dr. Plonsky, Tina Fung, Dr. Ye, and Dr. Mobley in sharing with us advances in Alzheimer's and research. So we will start with Dr. Plonsky. She is the Director of Scientific Engagement at the Alzheimer's Association, and she will presenting what is occurring on a global and national level with a review of highlights and trends. So please welcome Dr. Plosky.
Thank you very much for having me, and hello everyone. I am pleased to be sharing some of the latest research updates coming out of the Alzheimer's and dementia research space. This is going to be a whirlwind tour of the latest research, but also here to answer any questions that you all have. But if you go to the next slide, you'll see really the three buckets that I'm going to cover today. So we're going to cover a little bit on risk reduction research and really building upon the US Pointer study. I'm going to talk a little bit about where we are with early detection and diagnosis, really focused on where we are with blood tests and that form of early detection. And then also go into a little bit of treatment and care and where the research stands right now, and also some resources and some things to look forward to over the next 6 or so months. So if we go to the next slide, and we're just going to dive right in. I know you heard some research updates on the US Pointer study in your last meeting. But since then, we've had even more results be reported out from the US Pointer study. So I'm going to give you all just a little bit of an overview as to what this study is, just in case you missed that last meeting, give a little bit about some of the findings that we had, and then also go into those new results that we are learning about and continue to hear about in the latest research. So to start off, US Pointer, just to refresh everyone, is the US study to protect brain health through lifestyle intervention to reduce risk. It's a mouthful, that's why we just call it the Pointer study. But one of the sites for this was in your backyard. We had 5 sites across the US, and one of those being in San Francisco. And so if we go to the next slide, you can see a little bit about nope, go back one more. There we go. So this is what we did in the US Pointer study. Like I said, this happened across 5 sites in the United States. This is building upon a study that was done in Finland many years ago. I think that study reported out in 2017 or 2018. So this is building upon previous research knowledge. And for this study, what we did is we were really asking the question of, by combining multiple lifestyle interventions in one study, would that help with our brain health? Would that reduce our risk of cognitive decline in the long run? So for this study, we went about it with 2 different groups of people. One group was a self-guided, meaning that it was really just up to the participants to take what guidance was given to them about a healthy lifestyle. It was up to them to implement it into their day-to-day life. The other side of this study was a much more structured side of this intervention with many different peer team meetings, a lot of hands-on guidance as we think about implementing what a recipe for lifestyle interventions could look like. And this was combining physical exercise, nutrition, cognitive and social challenges, and health coaching in general. This was a very structured intervention, and the Pointer study was really comparing general healthy lifestyle and if that would benefit brain health, but if that more hands-on and structured would be even more beneficial to our brain health. So if we go to the next slide, you can see the study results, which again, you heard about these previously, but just to highlight that in both of these groups, both the self-guided and structured, we saw a positive benefit in cognitive function. So really thinking that no matter what, if you're focused on brain health, and you're focused on these healthy lifestyle changes, that is going to benefit your brain and that cognitive function. But that structured intervention had an even significantly greater benefit on cognitive function. This was just that first headline, top line results that we saw. But there were also many other studies that were happening in parallel during the US Pointer study, and these are called ancillary studies. These were funded by the federal government, and if we go to the next slide, you can see some of these results that were reported out. I think it was at a conference in December. So that last slide was reported out in the summer, and the top line results from the US Pointer study. But through these ancillary studies, we were able to show that the structured intervention of the US Pointer study had even more benefits than we saw in that initial study. So even beyond cognitive function, you can see that, and I'm not going to go through all of these details, but really what we saw is that the structured intervention helped with blood pressure regulation. So really connecting the structured intervention with blood pressure and heart health. We also saw that the structured intervention also had significant benefits on sleep. So this helped improve sleep apnea in these participants. And we also even saw some changes. We saw some benefit in certain imaging biomarkers. So when we were taking images of these individuals' brains, we also saw some positive changes in that structured group. Really just emphasizing that this structured lifestyle intervention really did improve brain health and cognitive function in these individuals. And we're continuing to do more analyses on this. It was done in over 2,000 participants. And so we are going to keep moving this forward and keep understanding what's happening in these participants. We're continuing to follow them for at least 2 years after they have finished the initial study. And we're going to continue doing analysis on all of the data that we collected. So I'm pretty sure we'll be continuing to come back to this group to share more exciting results from the US Pointer study as we continue doing that analysis. But just wanted to share this snapshot that the structured intervention really does continue to show significant benefits in this group of participants. So if we go to the next slide, kind of leaving that idea of risk reduction and what we can all be doing today, no matter what, thinking that those lifestyle changes that we could be making from the US Pointer study could be done across our entire lifespan. But wanting to switch gears here a little bit and think about the diagnosis process and thinking about early detection and why that's so important. And so currently, Alzheimer's disease is diagnosed with really a whole host of various tests. It's not going to be one singular test that can determine if somebody is living with Alzheimer's disease or another dementia. So doctors will really use a combination of these tests. That'll include a physical exam, a neurological exam, cognitive testing, and the one that I'm going to draw your attention to here is really the biomarkers. So thinking about the imaging biomarkers so that we can take a picture of your brain and see if you have the hallmark brain changes, but also the newer and expanding areas of biomarkers is really thinking about the fluid analysis and thinking that we could measure these brain changes in the blood of individuals. And if you go to the next slide, this is showing some updates and really just showing that we had the first FDA-approved blood test for Alzheimer's disease approved earlier last year. I believe it was in May. I do want to note that there are a few changes that I will make verbally to the slide as we go through it. So just putting that out there right now. But really, this LumiPulse blood test was the first blood test that was FDA cleared to diagnose Alzheimer's disease. Using this in combination with those other tests, knowing again that there's not one singular test to diagnose Alzheimer's disease, but that this test has been approved for individuals with cognitive impairment. So blood tests really being used for people with cognitive symptoms in specialty care settings. So that being used in primary care settings should say specialty care settings. So in individuals with cognitive impairment in specialty care settings, this blood test could be used to help a clinician diagnose Alzheimer's disease. This is able to detect those small brain changes that are happening really in as early a stages as possible. This is really exciting and really a step that we're going to continue expanding upon, and we've seen even more progress since that first FDA-approved blood test came out earlier last year, or middle of last year. So this is really exciting that we now have blood tests and they are being used in clinics, but we also need to be informing and educating clinicians on how to use these tests, when to use these tests, and who to be using these tests on. Again, noting that the FDA really recommends that this LumiPulse blood test be used only by specialists in people with symptoms. So if you go to the next slide, you can see some work that the Alzheimer's Association is doing in collaboration with specialists, clinicians, subject matter experts on bringing these blood tests into specialty care and creating clinical practice guidelines for clinicians to use and be informed on when to use these blood tests in clinic. And really the questions that we're asking now is, should these blood biomarkers be used as a triage test for patients? And could they potentially be used as a confirmatory test? So after you've done maybe a brain scan, could this be used additionally here as well? But that's just a little bit on some of these clinical practice guidelines. And if you want to learn more, I can put some links into the chat for everyone. But I know I'm close to time, so I do want to go ahead and jump to the next slide and highlight where we are with therapies for Alzheimer's disease, noting that we have many different treatments for symptoms of dementia, including cognition and function, mood and behavior, that you can see on this slide. But one thing that we'll talk about in more detail is where we are with the treatments that slow disease progression. And this is lecanemab and donanemab. Both of them are in purple on this slide. These right now are FDA approved for slowing disease progression in mild cognitive impairment and mild dementia. There are currently ongoing clinical trials for these to be used in individuals that are asymptomatic, meaning that they have the biomarkers, they have amyloid beta in their brain, one of the brain changes in Alzheimer's disease that these treatments target, but they do not show symptoms. So those clinical trials are currently ongoing. So we may see some changes to this image in the next few years. But to go a little bit deeper into what these treatments are doing, if you can go to the next slide. This is just a quick deeper dive into this new phase of treatments. Again, both of these target one of the underlying brain changes in Alzheimer's disease, amyloid beta, and can remove it from the brain, which has been shown to slow disease progression. And as we've seen, research has continued to come out since then, showing that there is even more of a benefit from starting these therapies even earlier. So as early as the cognitive symptoms begin to appear, these treatments have been showing benefits for individuals that are able to take them. And if we go to the next slide, just to highlight really where we are in the treatment landscape. Again, we have treatments for symptoms, and we're continuing to add more to the approved treatments. But we have these two that target amyloid, but there are over 135 unique therapies being tested in clinical trials, targeting all aspects of the biology of the disease, not just for Alzheimer's, but also for all other dementias as well, as we continue to think about the future of Alzheimer's disease treatments. If you go to the next slide, as I finish up here, want to highlight Trial Match, which is a clinical trial matching service for anyone interested in learning about clinical trials happening near you. This is completely free, and you're able to see the clinical trials happening in your backyard. We need both healthy and cognitively impaired individuals to participate in research to help us add more therapies to that FDA-approved list that I showed you. And if you go to the next slide, this is just a snapshot of some resources. Again, if you have any questions, you can go to our website and learn more about the latest research. And the next two slides are just some conferences that are coming up. This one is called AAIC for All. It's completely free, and you'd hear the latest updates in research directly from the clinicians themselves. This will be where we're going to hear some more continuations from the US Pointer study. This will be happening later this summer. All you have to do is register, and you can watch it for 30 days after the fact. And the next one is just to highlight, because it is happening in your backyard. This is a conference for individuals impacted by younger onset dementia. So really anybody with cognitive impairment under the age of 65 is welcome to attend this conference online and in person to learn more about the latest research for younger onset dementia. And I believe I just have one summary slide. Yes. So in summary, the Alzheimer's Association is a leader in Alzheimer's and dementia science. And that was just a snapshot of a lot of the research happening around the world and Alzheimer's and dementia. There's new tools for detection and diagnosis, new approved treatments, and more in the pipeline, strategies for risk reduction, and hope in research. And I hope that I was able to show that to you today. And I know that this was also thinking about not just what's happening in California, but what's happening more broadly. And so one big win that I do want to mention is that earlier this week, we had a $100 million increase in federal funding for Alzheimer's and dementia research, bringing up the total amount of funding from the federal government to Alzheimer's and dementia to $3.9 billion in federal funding, which is great, and will continue to move this pipeline forward and help us make even more progress. So with that, I will pass it back.
Sorry. Thank you so much, Dr. Klosky, for sharing what's going on in research and the much needed increase in funding that you've just shared. And I think Carlos is what will help us with the next presentation.
Yeah, thank you. Next, we'll hear from Tina Fung, Chief of Alzheimer's Disease Section, California Department of Public Health, and Harman Ye, who is an assistant professor at the Institute of Health and Aging. Tina and Yarman will provide an overview of current California investments in Alzheimer's research. Welcome, Tina and Yarman.
Great, thank you, Carlos. Good morning, everyone. Again, my name is Tina Fung, and I'm with the Alzheimer's Disease Program within CDPH. Can we advance to the next slide? So here in California, we're committed to supporting research in Alzheimer's. From the state level, legislation in the 80s enabled the establishment of the Alzheimer's Disease Program and several diagnostic and treatment centers, later named the California Alzheimer's Disease Centers. And legislation also required grant administration for research. According to the 2018 report to the legislature, since 1985, the state has invested more than $90.7 million in the California Alzheimer's Disease Centers, or CADCs, which then leveraged the funds to raise additional research funding. And around 2018 and 19, that was around the time the governor's task force on Alzheimer's prevention and preparedness was established. There was a big push for additional support in funding. As recommended by the task force in their publication, one of the recommendations was to accelerate investigation into Alzheimer's by increasing funding to keep California at the forefront of research that focuses on populations historically underrepresented, such as women, communities of color, and the LGBTQ+ community. Next slide, please. So CDPH awarded 3 cohorts on research projects from 2018 to 2022. These are primarily 2 to 3 3-year grants. And so here's a list of publications from our funded research projects. We have a long list of publications. On to the next slide, we have additional publications to share from these research grantees. And then the next slide. So for current funding, in 2024, CDPH released a funding opportunity focusing on health disparities in response to that task force recommendation. The research focus required a focus on priority populations. So applicants had to focus on a specific population experiencing health disparities, but they could also have the option to select an additional focus area for this particular funding award. And I want to note that ADP is in the middle of our webpage revamp, so we will have more specific information of these research cohorts. Since then, we have awarded 7 research projects. Next slide, please. So here are the 7 research projects. So we have studies ranging from risk prediction to screening to caregiving, in populations ranging from Latinos to American Indians to refugees and immigrants. Next slide, please. And so several of our initiatives that was supported by the task force has ended in 2024 and 2025. So while we don't have the resource to continue local community education, we are committed to serving as a resource hub and have framed our priorities as the Brain Health Coordinating Center. So at this time, we will connect our research partners with health providers and local health jurisdictions and community-based organizations by providing opportunities for researchers to share their work. We want to create a space for Alzheimer's interest holders to communicate and to foster intersectionality of healthy living, disease prevention, healthcare, and policy. We are also using this time to evaluate our work thus far. So we have 2 projects to evaluate past initiatives and to update a report on ADRD prevalence in California. And I want to emphasize the importance of evaluating our work, as this will inform us on how to navigate future research opportunities. So I wanted to pass along to Dr. Jarman Ye. She is one of our current funded researchers. Her research is focused on caregiving, but she is also in charge of updating the latest facts and figures. So Dr. Ye, take it away.
Thanks, Tina. Next slide, please. So, hi everyone, my name is Jarman Ye. I am faculty at the Institute for Health and Aging at UC San Francisco, and just truly a privilege and an honor to be working with the California Department of Public Health to update this report. This is a report that my colleagues and I have been doing since 2009 was the first one. There was a second one in 2021. And then this report, I'm going to give you a sneak peek, should be out later this spring with all of the data and the details that you might want to see in it. So this is just a high level overview. So next slide, please. So here we see the projected number of Californians age 55 plus living with Alzheimer's dementia from 2025 to 2030, 2040, and 2050. And I just want to make a quick note on terminology. So we follow the Alzheimer's Association in using the term Alzheimer's dementia to refer to dementia believed to be caused by Alzheimer's disease based on clinical symptoms rather than confirmed through tests or biomarkers. And that's primarily because population-based prevalence studies lack significant data to estimate cases confirmed by biomarkers. So that's just kind of sort of too early to sort of do that. And so that undergirds all of the projections that I will be talking through in these slides. The other sort of piece just to highlight is that we certainly know that age is one of the biggest risk factors for Alzheimer's dementia, and we see prevalence increasing with age. And so we understand that the baby boom generation all will be 65 plus by 2030. And by 2040, we will have a significant portion of baby boomers who are age 85 and over. And so we'll see some big shifts between those decades. And then the third piece that's undergirding most of the data that I will be sharing with you today is also the changes in California's demographic, because we use that to estimate our prevalences. So here on the left-hand column in blue with the sort of white dots in it is the 2025 estimation for Californians age 55 plus living with Alzheimer's dementia at approximately 721,000 people. And then moving all the way to the right, by 2050, we estimate that there's going to be 1.45 million Californians age 55 plus living with Alzheimer's dementia. So certainly a vast increase in numbers there. Next slide, please. This slide is largely the same information, but presented a little bit differently. This is the projected percent increase in Californians age 55 plus living with Alzheimer's dementia, compared to the California population total, as well as the California population age 55 plus with or without dementia. And so what you want to pay attention to is really the slope line difference. So the orange line with the triangle sort of markers on it is representing California's total population. So between 2025 and 2050, we anticipate California's total population only growing by 4%. Whereas if we pay attention to the blue line with the blue dots, that represents Californians living with Alzheimer's dementia who are age 55 plus, and that will grow 101% between 2025 and 2050. So the takeaway message here is really that Alzheimer's dementia prevalence is growing much faster than the overall population and much faster than the purple line, which I haven't talked about, which is California's population age 55 plus. Next slide, please. So this slide really just summarizes the last two slides that I talked through, which is that California's dementia prevalence will change from 721,000 in 2025 to 1.45 million by 2050, which is a 101% increase, so a doubling by 2050. Next slide. This slide represents the projected age group distribution of Californians age 55 plus living with Alzheimer's dementia. And so what we see here in the blue columns with the little white dots are for the population age 55 to 74. And in the purple columns, we see the population age 75 and older. And what we can definitely take away from this slide is that the 75 plus age group comprises the majority of the cases across all years from 2025 to 2050. So older age group grows substantially while the sort of the younger population age group stays relatively flat across these decades. Next slide, please. So this is the take-home message from the last slide. The prevalence by age 75 plus, will increase 132% between 2025 and 2050. So that will change from 526,000 people to 1.22 million people by 2050. Whereas in the younger age group, those between age 55 and 74, will see an 18% increase, a 194,000 in 2025 to 229,000 cases by 2050. Next slide. Okay. So this slide is the estimated prevalence of Alzheimer's dementia among Californians age 55 plus by sex. And what we see here in the blue columns are men, and what we see in the purple columns are for women. Women consistently have a higher prevalence than men, and the gap persists but slowly narrows slightly in sort of in relative terms. But both sexes show significant growth through 2025. Next slide, please. So the takeaway here is that for men, there will be a 107% increase in Alzheimer's dementia prevalence between 2025 and 2050. So that number will grow from 303,000 to 627. That should be a K, 627,000 by 2050. And for women, it'll be a 98% increase, but the absolute number of women living with dementia is much greater than men at 417,000 in 2025 and growing to 825,000 by 2050. And I just want to sort of make an editorial note as to sort of why that is. For those that might be curious, one of the reasons for the disparity that we see between men and women has to do with lifestyle differences, and also women living longer than men, increasing also their risk for Alzheimer's, dementia in later life. This slide is the estimated prevalence of Alzheimer's dementia among Californians age 55 plus who are lesbian, gay, or bisexual. One of the reasons why we don't have our transgender population here represented is because the cell counts just get too small for it to show up well in our data without some errors in our estimations. And so what we see here is in 2025, there's an estimated 17,000 people living with Alzheimer's dementia and growing to 32,000 by 2050. Next slide, please. And the takeaway from that is that we will see a 91% increase in the LGB community between 2025 and 2050. So it nearly doubles in population, underscoring certainly the need for more tailored and culturally competent dementia care for this particular population. Next slide, please. Okay, I know this slide is busy, but this is the slide breaking down the prevalence by race ethnicity. And so we've got categories from left to right: white non-Hispanic, Hispanic any race, Asian non-Hispanic, Black non-Hispanic, multiracial non-Hispanic, American Indian, Alaska Native non-Hispanic, and Native Hawaiian Pacific Islander non-Hispanic across the bottom. And what we certainly see here is that the white non-Hispanic population has the highest absolute numbers, but the slowest growth. Hispanic populations shows dramatic acceleration in prevalence. Asian population is the second largest by group, and especially shifting into 2050. But all communities of color show steep trajectories of increase in Alzheimer's dementia across these decades. So the next slide, please. So some of the high-level takeaways from that slide are that the Hispanic population will see a 192 increase by 2050, so that nearly triples the number of people living with Alzheimer's dementia. Native Hawaiian and Pacific Islanders will see a 154% increase, so over double. And then the other, next slide, please. And then the other sort of fast rising groups include the Asian American population, increasing 135% by 2050. People who are multiracial, increasing 135% by 2050. And then next slide, please. Black African American population increasing by 134% by 2050, so also doubling. American Indian and Alaska Native population increasing by 90% by 2050. And then last slide, please. And then among the white population, a 49% increase, which is much smaller compared to all the rest, but certainly, again, in absolute numbers, representing the largest numbers of people living with Alzheimer's dementia. This slide is representing the different breakdowns by geographic counties. And so we clustered California's 58 counties into rural, suburban, and urban categories just to estimate some of the prevalences that we're going to see. So urban areas will see a 109% increase in people living with Alzheimer's dementia between 2025 and 2050, the largest growth. Whereas rural populations will see a 45% increase across those decades, and suburban populations will see a 75% increase across those populations. But I think, again, important to note is that this is undergirded by some of the demographic shifts that we see. And we know rural areas face significant disparities in terms of access to resources as well as workforce barriers and services to care. So certainly more attention needs to be paid there that these numbers don't fully capture. Next slide, please. And then so this is a summary again, sort of the top line takeaway of what I had just mentioned. Largest increase across urban counties, followed by suburban counties at 75%, and then rural counties by a 45% increase by 2050. And then next slide. This slide demonstrates the percent change in age-adjusted rates for leading causes of death in California. The death rate decreased in California by 4.9%, and that's represented by the purple column in this graph between 2018 and 2023. California actually shifted from third leading cause of death in 2018 to fifth leading cause of death, so has gone down. This is certainly a good trajectory to be on, that there is declining mortality, but it doesn't mean declining burden for people living with Alzheimer's disease and their caregivers. So next slide, please. And that's the high-level takeaway. There's going to be a full report soon. I think one of the things that I want to mention is the full report will have the breakdown by each of the 58 counties in California. And other sections of the report will also talk about caregiving among Californians, as well as cost breakdowns, the social cost of care for people living with dementia, as well as the cost to businesses. Those are just the quick highlights. That's my contact information.
Well, thank you both for providing that compelling overview. As a family caregiver, it's kind of eye-opening. I'll hand it back to Wynn to introduce our reactor panelists.
Great, thank you again, Jarman and Tina. And now Dr. Mobley is there. So one of our committee members will help us with some of the discussions that was just presented regarding the research trends, just to kind of, what does this all mean? We heard a lot about the new diagnostic, ways to reduce dementia. Then we heard from Jarman that there's the increasing numbers. What does it all mean? So Dr. Mobley, you want to help us with this? And
yeah, I'd be happy to. So what a stark picture. We're presented with Jarman's data. I guess one quick question for Jarman. Do we have an estimate of the actual cost to families and to the government for caring for people with Alzheimer's disease now and in 2050? Do we have estimates for that?
Yeah, that will be part of the report. So we're just fine-tuning our calculations and double checking them to be sure that they're accurate. But there is a huge financial cost to families, both in terms of the social cost of care and out-of-pocket care that they provide to support people living with dementia.
Yeah, I mean, it's really overwhelming, really. Right? So faced with this incredible onslaught, I just have to thank the Alzheimer's Association for having done a fantastic job in advocating for families and caregivers, but also for funding for research. It's really a hugely powerful organization, and we're all indebted to the Alzheimer's Association for that. Courtney, could we go? I wonder if we could go to Courtney's deeper dive slide really quickly, because I think I can make some comments about where we stand in terms of development of new treatments using that slide. I think it would be helpful. I can't remember what number it was, Courtney, but if we could get that would be great. It's way back, yeah.
That the new phase of treatment slide?
It's close to that.
Okay.
It's the deeper dive where Courtney looks at A beta essentially.
It's the Alzheimer's, Rosie. You need to go all the way back.
Yeah.
It's the presentation before this one.
It's probably, yeah, I don't know what slide it is, unfortunately. But I think it's worthwhile waiting a little bit to get that up here because it makes it easier for me to talk a little bit about where we're going. Yeah, one more back. Yeah,
Right
good.
there.
Right there. That's great. So let me just focus on, yeah, let me focus on this. No, no, back one, please. Yeah, there you go. Stay right there. Let me focus a little bit on A beta. And so that little yellow streak, that little kind of backward C-shaped structure in the upper left there, that's A beta. That's A beta 1 to 42. And what the slide shows is that the individual A beta molecules clump together into something called oligomers. And then, in fact, so actually, let's start at the very top. The A beta monomers are shown in the very top. They clump together to make oligomers, and then they make these things called protofibrils, and they also make plaques. So logically, research is targeting that process. So one form of therapy is to prevent the production of this peptide altogether using molecules that reduce the level of the APP protein, the full-length protein. And that's a study. There are 2 studies ongoing right now, and I think they're very promising. A second strategy targets the production of A beta itself, those monomers. There's a trial now carried out by Roche, and there will be soon one involving UCSD and Harvard, in which we're looking at can we reduce the level of those A beta peptides? And that'll be a pill that you take every morning and every night. The next approach, I think very helpful approach, is to ask the question, can we prevent those oligomers from forming the protofibrils, that section in the middle where the lecanemab dotted line is there? Can we prevent the oligomers from making those protofibrils? And that's a company that has a small molecule that again appears to prevent aggregation of the A beta peptide. Another approach is targeting the plaque and the protofibril, and that's where the donanemab and lecanemab come in. They're very useful, but the question will be, is clearing plaques from brain, which they're able to do very effectively, is that going to be enough? Now, the good news is it is possible to clear plaques from the brain. Very, very good news. The second good news is that some of the markers, that phospho-tau marker that we talked about, is also reducing. The not such great news is that the degree of cognitive loss continues, albeit at a slower rate. And another bit of bad news is that for some people, those drugs can, in the right setting, induce changes in the blood vessels that feed the brain, with either edema, fluid around those vessels, or sometimes hemorrhage. Now, generally, those changes are asymptomatic, and one can always adjust the dose. But I think you see that there's a lot of effort and energy going into developing rational therapies for AD. What you don't see here is how A beta induces the phosphorylation of this tau protein. And the truth is we don't know how. But there are also therapies targeting tau through reducing the expression of the tau gene or perhaps targeting those aggregates of phosphorylated tau. I think the overview here is that the research that's going on now is incredibly encouraging. And I think the fact that the Alzheimer's Association and this committee are so supportive of research, I think brings us a much happier future in mind. And I really believe that the efforts that are going on right now will in fact deliver therapies that within the next 15 to 20 years will be able to treat Alzheimer's disease effectively and ideally and hopefully be able to prevent it. So we see this incredible wave of new cases of Alzheimer's disease, and our hope in the research domain, and of course on this committee and more generally, is that these incredibly important efforts at therapy should be successful in basically turning back the clock, if you will, to a time when we had many, many fewer cases of Alzheimer's disease, and ideally someday, both rurally and in urban settings, both in the US and in the world, no cases of Alzheimer's disease. So I want to say that I'm really encouraged by the progress being made, and I'm eager to have therapies that are easy to take, that can be easily sort of distributed by primary care providers who are very well informed about the diagnosis and the treatment of Alzheimer's disease.
Oh, sorry. There we go. Thank you, Dr. Mobley, for sharing that insight. Can we go actually back up to those slides and 2 more down? If you still have them.
So maybe slide 27.
Yeah, I just want to highlight, and thank you for highlighting the amyloid, targeting amyloid. But I think, as you saw on one of the slides, there are so many different possible causes of this. And so you can go down a little bit.
I think it's this one.
So we just really want to highlight it. You can see that there's amyloid beta as one of those causes in that circle. And the other things that Dr. Klosky presented, the way we prevent things, are targeting some of those things that you see there, right? The neuroinflammation, vascular stress, the physical exercise, aerobic exercise. Hopefully, the more people learn about the way we can reduce dementia of any type, not just Alzheimer's, hopefully what Jarman had presented will not be a reality. Hopefully we can reduce those numbers. I do know that we have this presentation about Alzheimer's today, but I was just at a meeting yesterday, but there are a lot of movements in frontotemporal and Lewy body as well. And in the future, we can have a forum for that as well, because I know we have new members who are representative of those other types of dementia. Dr. Ju.
I have a quick question. It's very informative. And I was just thinking about the Pointer study that our guest was talking about earlier. Is there any correlation around Pointer study and understanding a little bit more on the science, not just the results of that, the difference between in the Pointer study, the structure versus the lifestyle kind of thing? Is it in the inflammation, oxidative stress, or what are the KPIs that talk about it? Dr. Mobley's talk about, really about amyloid. Those are a lot of things that, on the bench side we're doing, but in terms of cost effectiveness, a lot of it will not be the biologics and the $50,000 to $100,000 per person. So if we understand a little bit more from the Pointer study, especially how it correlates to the science and the hypothesis, I think it will get more widely accepted as one of the many options to battle this disease.
Jerry, I agree with you. And actually, let's stay with that slide if we could, with the one we just shown, because I think it's really an important point to make about lifestyle changes in nutrition and exercise. One of the things that markedly increases your risk for Alzheimer's disease is social isolation and depression. And so I don't think we know precisely how that interacts with this circle of difficulties, but it almost certainly does. It almost certainly is the case that when you're with other people, that interaction with those people encourages your brain, nourishes your brain, supports your brain. And that's why I think the structured engagement was just more effective than the self-guided. So I think it's a great question. How do I relate social engagement to these markers of disease? I don't think we know yet, but it's almost certainly true, Jerry, that there is a relationship.
Yeah.
And I think once we know more about what it is to be with other groups of people and to share ideas and to get excited and joyful about life, the more we're going to learn how that's actually manifest in the brain and how that is disease preventing.
But in terms of I love what you said, but in terms of we need to, in science, quantification, is it PET scans, see which part of the brain is exercise or et cetera, because a lot of what I want to do, at least for what we're doing in Northeast Medical Services, is trying to make things that are affordable. Let me tell you, for example, food as medicine program is growing really rapidly across the country. We put up our own food as medicine program, but it's actually isolated right now. The benchmarks we're looking at is from diabetic control, things like PHQ-9 scores. We have not really pegged it to Alzheimer's, So if we know some of the pathways in the middle, like isolation, we're using isolation scores. So it'll be good to piggyback on some of the other movements that's growing in America right now, like food as medicine. Our own FQHC version of that is what we call community as wellness. So we do a lot of what was done in the Pointer study, a lot of coaching, guided social isolation and kind of activities on Zumba and meditation. But it would be fantastic if programs such as what we're kind of putting up, looking at A1C and stuff like that, have other endpoints that are measurable. That's what I'm trying to say.
Yeah, and I just want to jump in here real quick, just to add on what we're doing for the next step of US Pointer, and it really is to continue. We have blood measures from all of the participants, and so we're going to start diving in to really be able to answer some of those questions you were addressing. We have brain scans from a large majority of the participants as well, so we can start making those. We can start doing that analysis. We just have our first round just was reported out in July. And so as we continue to dive into those participants, we'll learn more. But we also are bringing this into community systems, and we are currently working on finding scalable approaches to the US Pointer study, knowing that this structured intervention isn't going to be possible everywhere. And so we are currently funding, I believe it's 10 programs to start understanding how we can take US Pointer and implement it into day-to-day life. And I believe some of that work is happening at the US Pointer sites in California, in Northern California. So just wanted to bring that in there as well.
It looks like we have Barbara's hand up.
Okay. I mean, all of this is so encouraging and exciting, but it also reinforces for me that the pinch point is now and will grow even more so that it's about screening because it's not happening right now. So we've been working with the state on the population of people who are duly eligible for Medicare and Medicaid as it relates to the CalAIM program. And I'm very pleased that the state of California, I think first in the nation, adopted a quality measure related to screening. But that's how we know it's not happening because plans have to report how they are screening people over 65 in their patient population. And the numbers are really, really low. So if we don't identify people and identify them early, then so many of these advances that I think are coming our way, people are going to miss that opportunity to take advantage of them. Now, I am hopeful that with more advances, there will be more motivation to screen. So maybe this will sort of feed each other. But I do think that the work that's been done through the BOLD grants, both at the state level and the federal level BOLD grant funding, focused on early detection have been so important. We just need to do even more of that, and we need to be making sure that we have widely available screening tools that are appropriate for different communities because there are issues there with screening tools not being a good match for some diverse communities. So we just need to make sure that it's as level a playing field as we can get about access to screening, that screening's being done so that people can benefit from all of this amazing advance that's happening in research.
Just one brief comment from you as we're needing to move forward to our next topic. Dr. Ju?
Oh, I was just saying for screening, for FQHCs, I don't know if you guys have heard of the UCSF TabCat thing. We're actually about to deploy that. So a lot more needs to be agreed on screening. The current way of screening in PCP and the time limits and doesn't really work.
Thank you for that. As a family caregiver myself, trying to navigate this and hearing what I heard today, it's important that we recognize that family caregivers go through a lot of grief, and they can go through these types of webinars and information, still don't know what it all means. We're having a very difficult time, and information like this is really important. And how we take the information from the Alzheimer's Association and other organizations out there that are trying to promote wellness, and really have it sync with people who are living this day to day. It's critical that we get this information out there, and how to devise and promote wellness through our communities. So I just want to say thank you to these panelists for speaking up about this. It's very informative discussion, and we need to have more of this. So now I want to pivot and transition. I'd like to open up the floor to hear the community members who have comments or questions.
Sorry. You'd think I'd learn at this point. Sorry.
Right.
Okay, I'm done.
So yeah. So open up to the committee. Any comments or questions? Anybody?
See any?
If there is any comments or questions, we'll move on.
Let's see. All right. Well, we have Sarah, my BFF here. Now it's a public knowledge. CDA Deputy Director, Division of Policy Research and Engagement, joining today's meeting to provide us with more important updates on the Aging and Disability Lived Experience Advisory Board.
Wonderful. Thank you, Wynn. And wow, what an amazing meeting so far. I am so impressed by the quality of discussion and presentations and the comments that you all have. I'm just going to speak for a few moments just to give an update on where we are with the establishment of the Aging and Disability Lived Experience Advisory Board. For the new members who are not familiar with this effort really stemmed from a desire to see that the Master Plan for Aging is moving forward with the voices of those people impacted most by the issues that we're trying to address. So, we are really proud that we have 6 stakeholder advisory committees. Of course, the Alzheimer's Disease and Related Conditions Advisory Committee being one of those very successful committees. And you also are a model because you all weave in the voice of both the caregiver and the individual impacted by Alzheimer's or related dementia. So that's a really effective approach. But we thought, we need to think about how, for the broader issues impacting the MPA, we're going to take into consideration the voice of those older adults, people with disabilities, and caregivers throughout California, and to reflect the diversity of our state. So we were really fortunate to get funding from a variety of our Master Plan for Aging Foundation partners. And these partners then supported the establishment of this Lived Experience Advisory Board. And we have the Lived Experience Advisory Board is being facilitated and informed by our Equity Advisory Committee on Aging and Disability. And the idea is that we kind of have a through line from the Lived Experience Advisory Board to the Equity Advisory Committee, and then to our other 5 Master Plan for Aging committees to reflect on what we've heard and what we've learned from this process. So I'm just here to give you a brief update on where we are with this effort and what our next steps are. So Rosie, if you could show the next slide, I want to show a picture of the committee. So we had our first meeting. We had a really comprehensive screening process where we tried to recruit people from throughout the state representing older adults, people with disabilities and caregivers in kind of the all regions of California. And we're so pleased with the membership that we were able to identify. We have 12 members, and you can see all of the individuals here. They come from a variety of backgrounds, and we have touched on so many issues, not least of which are we hear from the caregivers. There's a caregiver who has cared for not only her mother living with Alzheimer's, but now her sister as well. And we hear so much about, just the difficulties navigating the system and the isolation and loneliness that caregivers often face. And we're also hearing a lot about issues of people living in rural communities and the challenges of transportation and what that means. Also, the importance of culturally responsive programs that meet the needs of the range of populations in California. So we're really excited about this effort. Our next steps are that we're going to start taking clips of these meetings and putting them on the website so people can learn and hear from our Lived Experience Advisory Board. And we are really pleased that with the support of our MPA Foundation partners, we've had 3 meetings and we're going to be able to have 5 more by the end of this year. So we're hoping that over that time period, we can continue to elevate the voices of our advisory board members and inform the other stakeholder advisory committees, but more importantly, inform the state and the legislature about what we're learning and how that informs the master plan for aging now and moving forward. So I'm happy to answer any questions, but I really appreciate the opportunity to give you an update on this committee.
Thank you so much, Sarah, for your continued leadership and sharing these important updates. Any comments, questions from our committee?
I have one. Is it possible for the public to attend these meetings as well?
That's a great question, Kate. And so we started, to date, they have all been closed meetings because we wanted, they're sharing a lot of personal experiences. However, I will note that they have been so open and they've given us, their consent in sharing clips and sharing the videos. So with that said, we haven't determined yet that it will be open, but if there's an interest, we can always figure out if there's a way to have, some sort of engagement with the broader public. So I appreciate that, and we'll take that back for sure.
Anyone else?
Thanks, Sarah. We appreciate that.
Thank you, Carlos.
Up next, I would like to welcome Connie Licano, CDA Assistant Director of Office of Strategic Initiatives and Equity, joining today's meeting to provide us with an update on the CDA statewide website.
Thank you for that introduction, Carlos. Good morning, everyone. I'm Connie Nicano with the Department of Aging. I'm the Assistant Director over Office of Strategic Initiatives and Equity, and just wanted to give you guys a little bit of an update in terms of what we're doing with our website. If we can go to the next slide. Okay, we wanted to talk a little bit about how we're supporting caregivers through clearer aging information. So when a lot of folks come to us, or when we get the phone call or the email, they're often dealing with, something that's very complex and stressful. And for many, the website is where they often start. The first step tends to be, if the first step is confusing and there's a lot of barriers, it can be very daunting. And this is what we're looking to do, is to make the information more clear, easy and accessible for caregivers and older adults. Next slide. So CDA has done a lot of research over the past year, including a lot of surveys. We've done focus groups and analysis on how people are actually using our website and how they're getting their information. And across all of this work, the same themes usually come up again and again, regardless of background, age, or geography. And a lot of it is very similar. What they really want is clear, easy, accessible information. Next slide. So just reinforcing that people aren't asking for more information. They're just asking for clear information. They want the starting point that they can trust, language that they can understand, and guidance on what to do without feeling very overwhelmed. And the next slide, why this matters. It's especially true, for caregivers supporting someone with Alzheimer's or related condition. Caregivers are often searching under pressure and at moments of transition or crisis. And when information is scattered or it's very hard to navigate, it can delay access to support. So really improving clarity and the organization of the information really helps people find the answers faster. So we'll go into a little bit more about what we're doing now. If we can go to the next slide. CDA is looking at redesigning our current website, the agingca.gov, to better reflect how people actually search for aging and caregiver information. This isn't really about, changing any programs. It's really just improving how our information is presented so people can find what they need, at their fingertips and very easily. Next slide. So the redesigned site will roll out in phases. It'll start late this spring or early summer. We're kind of targeting around the May timeframe, but it may be early summer. Improvements will continue over time, but we just wanted to share this as an FYI with the network because we all support similar communities. And this is also going to help the communities that you serve as well and align with the goal of making information easier to access and more accessible. So we just wanted to share this update with you guys, to be aware that we'll be redesigning our website and have the information out there. And that's it. If anyone has any questions, feel free to send them my way.
Thank you, Connie, for that update. Caregivers get a lot of information, especially in the beginnings.
Yep.
Next, if anybody doesn't have any questions, I think we're going to move on to taking a 15-minute break. Carol, please proceed with the break, and we'll see everyone after 15 minutes.
Thank you. Let's go ahead and put up the break slide. And we have 11:34. We will be back in 15 minutes, which check me is 11:50. Is that 15 minutes? Meeting will resume at 12 o'clock.
Yeah.
I think that's wrong.
It worked.
That's right.
It works, yeah.
We're 10
All right, have a break. You can make sure you mute yourself and we'll go ahead and mute the room. Thank you, everyone.
Is it me or you?
I thought it was you.
All right, so welcome back, everyone. I hope you had a nice break. So for this part of the segment, I'd like to introduce Ross Lalian, Chief of Research, CDA, and Lori Peterson and Miranda Kunkel from Collaborative Consulting to tell us about the Master Plan for Aging Midpoint Evaluation.
Thank you. Hi, everyone. Thank you for the opportunity to introduce the MPA Midpoint Evaluation. I'm Ross Lalian. I'm the Chief of Research with the Department of Aging, and I'm joined by Miranda Kunkel from Collaborative Consulting, who are partnering with on this effort. So Lori's not here, but Miranda is, and Miranda and the Collaborative Consulting team bring extensive research expertise and a strong ability to communicate technical findings for a wide range of audiences. We also have a solid understanding of the MPA landscape, which really makes them an ideal partner for this work. And we're going to tap into their deep experience with qualitative data collection on this project in large part, because at the heart of this project, it's about collecting stakeholder feedback. We want to hear directly from the broad network of partners who have helped implement and advance the MPA. We're 5 years into this 10-year plan, so this being a midpoint evaluation, we have a unique opportunity to reflect back on the past 5 years, what's working well, but also where there's room for improvements, we can better inform implementation over the next 5 years. Go to the next slide, please. So this slide outlines the high-level goals of the midpoint evaluation, and the central focus is going to be on the MPA's implementation elements. As I mentioned, understanding what's working well and where there's opportunities to improve. And Miranda will provide more detail on this in just a moment. This project is really about taking an honest look at the MPA implementation process to date. We want to hear all partner feedback, not this positive reinforcement and not just folks telling us that everything's great. We want to have those real conversations, get honest feedback that will really help us with the next 5 years of implementation. Another key goal of this effort is to raise awareness of the MPA. So this is a long-term plan, right? It's a 10-year plan, so we feel that it's important to highlight that we're in the thick of this plan still and focus on the critical policy issues laid out in the MPA. We also want to reinforce commitment across our network of partners and stakeholders as we move into the next phase of implementation, especially with the new administration on the horizon. And before I turn it over to Miranda, I want to thank our MPA Foundation partners for their funding support in this effort. They've been at the forefront of the MPA from the very beginning, and we're grateful for their continued collaboration. The MPA remains a strong example of an effective public-private partnership, something that we're proud of, and I think it's fitting that this midpoint evaluation is informed by our broad network of public and private partners, including all of you. So with that, I'm happy to help answer any questions at the end of the presentation, but Miranda, I'll turn it over to you.
Thanks, Ross. Hi, everyone. My name's Miranda with Collaborative Consulting, and I'm excited to talk with you all a little bit more about our midpoint evaluation of the MPA. If I could get the next slide, please. So this slide is showing what we will be evaluating, which, as Ross introduced, is the implementation of the Master Plan for Aging. So to define MPA implementation, we are adapting an existing framework. It comes from the Center for Healthcare Strategies. They call it the 6 key components of an MPA. So what you're seeing on the slide here is that framework. There's 6 components. And the CDA team and the collaborative consulting team are currently defining and tailoring these elements to really reflect the California MPA context. So we're using this as sort of our starting framework. I'll briefly just talk through each of these elements so you can start to understand how we are thinking about and defining these elements. So first, state leadership. This includes how aware, committed, and invested state leadership, including the governor's office and legislative leaders, are in advancing the MPA. Second, cross-agency development and accountability. So this refers to how CDA and other state partners are sharing the ownership, the roles, the accountability related to the MPA, and how they are collaborating or partnering on different MPA activities and initiatives. Third, you see stakeholder and consumer engagement. So this is going beyond, is stakeholder and consumer engagement happening, but really, how is it happening? Is it broad and meaningful and accessible? And we will be looking for examples of how that input from stakeholders and consumers are being used in decision making. Fourth, data-driven. So this looks at how data is being collected and how it's being used both internally among MPA partners and also sort of broader by stakeholders and consumers. So we'll be looking at how data is being used to track progress, inform decisions, and identify and address gaps. Fifth is living document. So this essentially means how adaptive is the MPA, how it's being revisited, updated, and refined, as opposed to being a static document. We'll also be looking at sort of how helpful those refinements are, just if there's anything within that process of being a living document that could be improved. And finally, having a broad focus on aging throughout the lifespan. So this includes the extent to which MPA implementation reflects a lifespan approach, recognizing that the MPA is for a lot of people beyond older adults. It includes family caregivers and people with disabilities and the direct care workforce and intergenerational priorities. So it's really beyond just older adults. Next slide, please. So we will be evaluating those 6 components from the previous slide systematically with a specific set of evaluation questions, which you're seeing on the slide here. So these are our 4 evaluation areas and just a sampling of the questions that we're hoping to answer within those 4 areas. So the first area is fidelity and progress. So we will be hoping to learn how implementation is progressing at this midpoint, and if the elements are being carried out as intended. The second evaluation area is barriers, challenges, facilitators, and supports. So we want to understand the positives and the negatives, what barriers and challenges are hindering implementation, as well as what factors are making implementation easier. Third, so this is perceived value and awareness. So here we want to understand the unique value that those 6 implementation elements are bringing, and what would be lost if they no longer existed. And finally, and again, this is really where the unique value of a midpoint evaluation shines, we can ask recommendations for improvement, sort of looking at the next 5 years of implementation. What recommendations for improvement do stakeholders have? And essentially, how can the 6 elements be improved to better support progress and success in the MPA? So in order to answer these questions, we will be using both primary and secondary data, which I'll talk a little bit more about on the next slide, where you can see just a timeline of our work. If I could get the next. Thank you. So on this slide, you're seeing a very high-level overview of our project timeline for this evaluation. And if you'll notice, right now we are in the very early stages. We're in month 1 of a 9-month project. So currently in sort of establishing the project foundation. So we are designing and planning for the evaluation to come. The core of conducting this evaluation will be happening in phases 1 and 2. So those, as you can see, are stakeholder engagement and existing data review. So on the stakeholder side, we will be engaging stakeholders who can speak to those 6 components of an MPA and help us answer our evaluation questions. It's likely that, with a wide range of stakeholders, we will be conducting interviews, focus groups, surveys. So really picking the best method that makes sense for the particular group or individual that we're hoping to speak to. To complement the stakeholder engagement, we will also be reviewing secondary data to look for examples or evidence of the elements of MPA implementation that are relevant to our evaluation. And as you can see in the timeline, it's intentional that we are running these 2 phases concurrently so we can sort of continually cross-check and validate what we're both learning from the secondary data and what we're hearing from stakeholders. So the latter half of the project focuses on analysis and synthesis and our next steps. So in phase 3, stakeholder input and the secondary data will be sort of coming together into a comprehensive evaluation. We will also be prioritizing deliverables at the end of this project that are really succinct and visually appealing and can be shared across stakeholder groups, with a key audience being the incoming administration. In the final phase, the CDA and collaborative consulting teams will be sort of reviewing the results, everything that we've learned from the evaluation, and start to discuss potential changes. Again, because we are at midpoint, we want to focus a substantial part of this project on, changes to MPA processes, content, systems, anything within that implementation framework that could be tweaked or refined in order to sort of amplify progress over the next 5 years. Next slide, please. So that was a very high-level overview, and Ross and I are happy to take some questions from the group, just general reactions, clarifying questions or comments.
Sharing the midpoint evaluation of the MPA. Committee members, do you have any thoughts to share? Barbara?
I'll just make kind of a global comment about, so I live in Los Angeles County, and I know that a lot of the master plan for aging is really focused on kind of state level activity. And I know there was some documents and efforts to support work happening in counties, but it's really hard to say that I see and feel master plan for aging work in LA County. And I know we're huge and complicated, and this is a really hard place to do pretty much anything. But I just think, if we're looking going forward, if there could be some maybe additional focus or support, I don't know what this would look like so that, and of course, the picture's getting even more complicated with counties. And I'll talk about this when I'm doing the legislative update about kind of what's rolling down the hill to counties to have to manage. So the timing is, maybe not great in the next few years. But I guess I'm just expressing a general feeling of I just really wish I could see more happening in LA County related to what what the goals are for the master plan for aging for the state.
Thank you, Barbara, so much. That's part of this process right here, those kind of candid comments. So the MPA is a state level plan. It's a big plan, right? It's a long-term plan. It's like local MPAs are like critical as well because the state's so diverse in so many ways. But I appreciate that feedback, and I think that that's part of this process to hear those comments. So thank you.
Right. If we don't have any more,
Can I add one thing, Carlos?
yeah, go ahead.
Yeah, just to add to it too, thank you. I know, we just wanted to make sure that you were updated that this process is happening. Remember, this is a 10-year plan, we're midpoint. We want to take advantage of any input that will help inform the work we do over the next 5 years. And so, there will be additional opportunity for all of you to weigh in as one of the Master Plan on Aging stakeholder advisory committees. So we wanted to make sure you're aware of it. So if you hear from us and we ask for your input or interviews or to do a survey or some way to provide additional input, you'll know why. It's in the context of ensuring that stakeholders like all of you are helping to inform the evaluation and helping us really think through the next 5 years of MPA implementation. So I just want to make sure you're aware of it, and there'll be additional opportunities for engagement. So thank you.
Thanks for sharing that. If we don't have any more comments or questions from the committee, I'd like to move on to our legislative updates. The portion of the agenda, please welcome Barbara McClendon, Public Policy Director of Alzheimer's Los Angeles, and Andrew Mendoza, Director of State Affairs at Alzheimer's Association. Thank you for talking about this.
Thanks, Carlos. I think I'm starting out, and then I'll hand the baton to Andrew. So if we can go next slide. I'm going to set the state, next slide. the big picture, and I think Susan mentioned this when she provided her comments as well. So the deficit that we knew we were going to be facing is less for this fiscal year than we feared it might be. So that is great news. But if you lift the hood a little bit, dig into it, there are lots of concerning clouds. And one of them is that the budget does include this expectation that within the upcoming fiscal year, about 500,000 people are going to lose access to Medi-Cal. And this is due to that the federal action, HR1, and Susan referenced this as well. So, across 2026, I think we're going to start to feel more and more impact from that legislation. We're going to feel it when it comes to nutrition services as well. It's getting a lot more expensive for states to administer CalFresh. So we're watching that really closely. And nutrition is a really critical issue for older adults broadly. We talked some earlier, Dr. Mobley, you mentioned the importance of connecting people, building opportunities for community. That's what those congregate meal sites offer. And so it's just, there's a lot of concern going forward about what these services are going to look like on the ground for older adults specifically and others who depend on these programs broadly. Next slide. So specifically, again, the governor didn't propose cuts that, again, we feared might be there if the deficit had been big. So, for example, cuts to the long-term services and supports that so many of our families and individuals rely on to get help in the community. There are some cuts proposed, though, for in-home supportive services that are concerning to us. And again, as Susan mentioned, the governor's proposal here in January or last month is a starting point. Lots of action in the Assembly and the Senate yet to come. A revision in May from the governor's office. So what the final picture will look like, nobody knows at this point. But cuts proposed would, for example, the first one would remove this opportunity for people who fall off Medi-Cal to be able to keep their IHSS while they're working out potentially, paperwork issues and whatnot. And the elimination of some funding for the IHSS provider backup system. And then, and I referenced this in my comments about the master plan for aging, just this kind of shift of costs down to counties, which are really struggling already to figure out how to balance their own budgets. And so in-home supportive services is such an essential program for basically everybody that is taking advantage of it. So we definitely don't want to see that program weakened in any way. That might make it more difficult for people to actually get their needs met through the program. So just some concerns for us to be keeping our eye on there. Next slide. Okay, so we are not to the bill filing deadline yet. That's in a couple of weeks. So there are not a whole lot of bills that have been filed on any topic yet, much less older adult, and specifically bills that impact people with Alzheimer's and dementia. So when Andrew and I come back at the next meeting, there's going to be a lot more that we're going to be talking about, but there are a few things that have been filed so far. This one here, Senate Bill 895, would put a bond measure on the ballot. And it is designed to support research in biomedical research, behavioral, and climate research. So again, authorizing $23 billion in bonds that would fill a hole that there had been some real concern at the early in 2025, across 2025, when we were seeing potentially massive cuts happening to research across a variety of topics. Research programs that were needing to pause because funding was being paused. And so this would be an effort to ensure that this really critical research can still happen, at least here in California. I believe the state of Texas actually passed a bond measure last year that is specific to funding research in Alzheimer's and dementia. So it's kind of interesting to see how states seem to be picking up the mantle from, again, what was feared to be lost at the federal level. Now, the budget they just passed doesn't cut that funding for federal research as we feared it might. But again, with all of the exciting work that's being done in so many spaces, including in our space, I think, more funding to boost that work certainly seems like something that would be beneficial for people who are living with Alzheimer's and dementia and their families. Again, if this passes, it would be the next statewide election that we all would get an opportunity to vote on it. Next slide. This is another one. The first one is a bill that's happening inside the legislature. This is actually something that somebody might stop you on the street and ask you to sign the petition to get it onto the ballot. This one is California Immunology Research and Cures Initiative. So the focus is on a specific kind of technology, this immunology research into health conditions like cancer, heart disease, and Alzheimer's disease. It is primarily driven by a billionaire philanthropist and medical inventor, Dr. Gary Michelson, and his wife. They have a medical research foundation, and it is a proposal to create a public-private partnership with the state of California connected to UCLA Research Park. So no who's to say at this point if it's going to get enough signatures to make it onto the ballot, but it is something that is being proposed. Next slide. Okay, great. Next bill. We talked a lot last year. We unfortunately started last year, of course, with those horrible fires. And so it really did raise awareness of the need to do more to better prepare a range of communities to deal with disaster and emergency situations. And so this one would be requiring the Aging and Disability Resource Connection Centers that are spread across the state to provide disaster and emergency preparedness training specifically designed for older adults and people with disabilities. And the bill also does direct these ADRCs to use existing trainings because there is quite a bit. I know the Department of Aging has done a lot in this space. So this is not saying reinvent a wheel and develop the training. It's saying it's out there, take it and make it available, provide it for older adults and people with disabilities in your community. Next slide. So Alzheimer's Los Angeles, Alzheimer's Orange County, Alzheimer's San Diego. I wanted to share with you all a proposal that we are considering for either legislation or there may be some other avenues that we can use in order to get at this issue of improving access to mental health, behavioral health services for people living with Alzheimer's and dementia and their family caregivers. And so this is an effort. Some of you who were on the committee last year, I think it might have been our February meeting where we had a caregiver who came and spoke about the challenges that she faced finding behavioral health services for her mother and for herself as a caregiver. So finding someone who understood the challenges of living with a dementia, understood the challenges of being a caregiver for someone who is living with a dementia. And so one possible path to trying to improve that understanding of what these individuals and families need may be a specific continuing education requirement that would add 4 hours, not add, that would specify that 4 of those hours that are already required, 3 would be on older adults and 1 with a focus on Alzheimer's and dementia. So like I said, not certain that this is actually going to end up as a piece of legislation because there may be some other avenues where we might be able to make some progress in this space, but this is the area that we are looking to focus on for 2026. And then next slide. I just wanted to give a little bit of an update. I feel like we don't really ever circle back and tell the committee what has happened with past legislation that we have discussed as a committee. So I wanted to share that legislation passed session before last related to developing guidelines for law enforcement to address people with a cognitive impairment, could be someone living with autism, when they wander. There really had not been a lot of guidance for law enforcement. There's guidance on missing persons, but not what we needed to see there for at-risk individuals. So that actually has been done. The Commission on Police Officer Standards and Training has issued that final guidance. They even went an extra step and created a video for law enforcement to encourage them to look at these guidelines, to use them when they are doing searches for the individuals that the guidelines speak to. And then a bill passed just this past session that related to ensuring that caregivers would be able to remain with their loved one in the hospital if they needed that additional support because of a disability, including cognitive impairment. It became effective January 1, but we already have heard from families. One story in particular of a family, this woman's mother was in the hospital in December. She is not a native English speaker. She is a Mandarin Chinese speaker, and she has cognitive impairment. And there was some issue about this caregiver being able to stay. And then she said to the charge nurse, "Hey, I know it's not January 1 yet, but there's this legislation and this is what it says." And it just changed the whole dynamic. And she was, sorry, I always get a little emotional because these are real people's lives. She was able to stay with her mom the whole time she was in the hospital. So these kinds of legislative bills that we support really can make a difference in people's lives. And I'll stop there. And I think it's Andrew now.
Thank you, Barbara, and definitely agree that the legislation that we work on can have a great effect. So thank you for sharing that story too. Great, it's very inspiring. So the Alzheimer's Association does have 3 public policy priorities this year that are, as Barbara said, working their way through the introduction process. So I can go over what they are now. So essentially, the first one is modeled after a successful effort in Illinois to require private insurance coverage for disease-modifying treatments for Alzheimer's disease. The language effectively captures the currently available monoclonal antibody treatments targeting amyloid plaque, but they could be inclusive of future developments as well, as the language would require for private insurance to cover anything that's FDA approved for the treatment of Alzheimer's. So Senator Weber Pearson, the chair of the Senate Health Committee, has introduced California's version, and there are some state-specific considerations for this bill. It is Senate Bill 950, and it is going to be banning step therapy for these anti-amyloid treatments. And this is in particular to avoid the use of Aricept as a precursor for either of the monoclonal antibody treatments that are targeting amyloid plaque. And then it is also going to make coverage criteria consistent with FDA indications for these treatments. And then it will make the IMR appeals, the independent medical review appeals, exigent. And this means that they have to be decided upon in 24 hours. So effectively, when someone has an IMR appeal, it goes over to the agency and the clock starts, but the agency can stop the clock and ask for additional information like scans or other documents that are needed to then render a decision. But this is going to speed up the timeline so that decisions will be rendered more quickly, so that if someone is in the early stage and they're encountering denial, that they don't exit their eligibility window. We're hoping that this legislation will calm the sense of anxiety associated with deciding whether or not treatment is the right step in the journey, as private insurance is one of the last barriers for access to care. I should note that Medicare has issued a coverage decision, so this is largely going to be something that affects younger folks that are still in the employment market or still in the job market, and receiving private insurance from an employer, or something along those lines, and not on the public program, because Medi-Cal also does provide coverage. So this is one of the last steps that we have control over. There are also federally regulated health insurance plans that Californians have that this will not cover. So don't want to indicate that this is going to provide some kind of universal coverage, but we're doing what we can. And the bill is going to be analyzed by the California Health Benefits Review Panel, or what is called CHBRP. And we're going to have an understanding of what coverage currently looks like for these treatments, and then what the impact to premium would be for the specifications made in the bill if implemented and enacted into law. So the bill will likely move forward after March, after 30 days in print, and we have a long road ahead. So definitely this bill could change in content, so we will keep you updated along the way. But do want to inform you all about this campaign, as we've already put in a considerable amount of effort into this project and to get it off the ground. The Alzheimer's Association is embarking on a similar effort in New York, New Jersey, Minnesota, Nebraska, and Pennsylvania this year, and they will likely be adding additional states to take action in the following years to expand coverage in other states as well. And then if we can move to the next slide, our budget request for $5.4 million to be made available for 3 years for Dementia Care Aware is the second item I'll be talking about. And this is for them to continue operating a dynamic training program on dementia screening, care navigation, and case management. DC has already trained 7,250 professionals in nearly every California county. And they've done this with in-person and remote sessions on their cognitive health assessment. And they also actively support the clinical implementation of these assessments, and they have been instrumental in supporting California's dual eligible special needs plans, or DSNPs, in fulfilling a new requirement around tracking older adult members who have had an annual cognitive assessment completed. And then they have previously partnered with California Department of Public Health's Alzheimer's Disease Program on Dementia Care California, which is a state-specific, physician-specific program with resources for treating individuals with dementia. And we are currently circulating a request letter amongst Assembly members for co-authorship. Assemblymember Patrick Ahrens is our champion for the request. He is also serving as a budget subcommittee chairperson. So we hope that that does help elevate the request, especially during what many of us understand is a difficult budget year and a difficult year for budget requests. And then we are looking to finalize a champion on the Senate so that it will be moving in both houses. But we do know that it will be considered in the Assembly at least. So definitely happy about that. And if we can move to the next slide. Our last item to talk about is an Assembly bill that will be introduced next week by Assemblymember Catherine Stephanie, that we are co-sponsoring with the San Francisco District Attorney. Essentially, a district attorney can allocate resources to establish elder abuse units and have them perform vertical prosecutions, where one attorney is assigned to each stage of the case. This improves victim services because it provides for continuity and avoids handoffs to other attorneys who are unfamiliar with the victim or their caregiver and may even lack expertise in issues that affect older adults. And this bill provides attorneys with cases where the victim of the alleged offense is an older adult, dependent adult, or a minor to receive a continuance. And this supports the goal of the vertical prosecution unit to work so that they won't have to do that aforementioned handoff if there are other obligations that arise for them. And the population that I specified is modeled after the Vulnerable Victims Unit in San Francisco. Ultimately, as I mentioned with the treatment access bill, that this bill may change a bit, and ultimately the population specification may end up as a charge type specification. So I'll definitely keep you all updated on this bill as it moves forward as well. And it does aim to recognize the increase in elder abuse and neglect that we have observed and provide a structural change that supports vulnerable victims and the governmental entities delivering essential services to them, so that we can have a more dementia capable framework implemented into our governmental infrastructure. And then that is the conclusion of our policy priorities for this year. Thank you.
Thank you, Barbara and Andrew. We appreciate those updates on our legislation. I see we have a question from.
Hi, Rhiannon, on behalf of Assemblymember Pellerin. I just wanted to kind of put a note of caution when it comes to the governor's budget projection. The LAO, the Legislative Analyst's Office, is still projecting a much, much higher deficit than the governor's very rosy 2.9 billion. So that will likely change. As my boss likes to say, it's a blueprint. It's not always reflective of what the May revision will look like.
Thank you for that. Anyone else? I have another question. Celine?
Thank you. Andrew, when you were talking about the state coverage for the medications, you alluded at the federal level, and can you elaborate more on kind of what the advocacy is happening at the federal level for Medicare in covering these medications?
The Center for CMS has already issued a coverage decision, so there is not a need to do any active advocacy. So what we're doing here at the state level is working to make a requirement for state regulated plans. And there is a bit of a difference if you are self-insured. Those plans are typically regulated by the federal government, and the federal government doesn't have a similar regulation for their private plans. So in that case, what we're doing wouldn't extend to that population necessarily. So I did want to provide that caution that in the future you may hear about coverage denials even with this bill enacted. So did want to make that note, but this is essentially the plans that are regulated by the California Department of Managed Healthcare and the California Department of Insurance. So they are plans that are sold in California. So as the Alzheimer's Association employee, our headquarters are in Illinois, so they buy insurance for us in Illinois. So there's other complexities associated with insurance that may also affect what individuals encounter when they're seeking treatment. But yeah, that is essentially a little bit about some of the differences amongst what we're aiming to do versus the insurance landscape. I don't know if that answers your question specifically, but
Yes, that helps. Thank you.
Okay.
Anyone else? Oh, Janine?
Sorry, I'm muting myself. I guess I was just thinking about their proposal for mental health providers to have 4 of their hours as part of CME. And as we're talking about like improved screening and need for improved screening, is that something that is being proposed to be expanded to other healthcare professionals in terms of geriatrics and dementia? To try to
So
get people screened?
not through the CEU path, but actually dementia care aware that Andrew spoke to, when we get to the conversation about what we should put in the secretary's letter, I would love to see our advisory committee support that budget request, because dementia care aware is all about screening and improving screening and providing tools for it. And I mean, if we want to improve screening, I think that's just a really important program to have as robust as possible in the state.
Yeah, just captured audience and a good way to get everybody to do it. Kind of.
Yeah, if I could just add on that, I would say that the Dementia Care Aware program, I think, is in recognition of the need for more training amongst primary care in specific, but it is definitely open to anyone that's a professional and does offer both CEs and CMEs. So anyone can sign up for a lunch and learn kind of remote training program, and then of course they do the in-person programs as well. And they are doing a lot of advertising to get those training sessions out to the public. So it may be something that they need assistance getting the word out on.
I just kind of harken back to when opioids were the big deal and we were required to do so many hours of opioid as part of our relicensure, you know, so as the aging population goes, right? Is that something to think about?
Yeah, it's certainly it's a great point. What we knew when we put the proposal out there is that professional groups do not like anyone to come
I
in
know, I
and
know.
lock down.
Let's say this with a grain of salt, as I would be subject to that
Yeah,
at the same token, right?
exactly.
It's a
Which is
two-edged
why
sword.
I may have sounded a little cagey when I was like, I
Yeah.
don't know if it'll be this because, you know, we're in many conversations and yeah, but I think broadly speaking, what has been gratifying is there is an understanding among all of these professions of the need to do better connecting people living with dementia and caregivers to appropriate mental and behavioral health services. So.
Wanted to circle around, see if anybody has any questions or comments before we move on. If not, thank you to everyone's comments and questions.
Okay, well, thank you to all of our presenters this morning. I think it's now time for our public comment. So Carol, I'll hand it over to you to start our first public comment of the year.
Wow, very exciting.
Yeah, it is. It is the first public comment of the year. Great. Hello, thanks for staying with us. This is the public comment period for our public attendees. If there's anybody in the room, I'm sure I will hear from you. Assuming not, those of you online, if you're appearing by phone, you can hit *9, or via the Zoom platform, you have a raised hand icon, so you can use that. And of course, at any time, you can send your written comments to the Engage email box at engage, ENGAGE, at aging.ca.gov. We accept those at any time. So if anybody would like to give a comment to the committee, you are more than welcome at this time. Lots of information today. So feel free if after you get off out of this meeting, if something comes to you, feel free to email us and we make sure to get it to the committee. Engage, ENGAGE, at aging.ca.gov. Carlos?
Yeah, I just want, I guess the comment is that as a family caregiver, this is all kind of like new. I guess I've been at this for 10 years, but I'm starting to learn more and more about the work that the CDA is doing and the Master Plan on Aging and what the health secretary is going to be, what we're going to recommend to the health secretary. But you know, we need to stay I guess together with this and build out this information so we can encourage family caregivers to, you know, engage with the websites, with the Alzheimer's Association, with the Alzheimer's LA and all the other organizations that are trying to help. A lot of family caregivers don't know where to turn for help. And this is why this committee is very important for us to understand that there is caregivers who are out there suffering. They're in the middle of grief. They don't have access to the hospital to stay with their loved ones who are having these hard moments. It's just not the person living with the disease, it's the family. And we need to understand that because we're not numbers, we're not on a data graph. We are humans that are struggling with this, and this work is important. And I just wanted to voice that because it matters. So thank you for everybody that spoke up, and hopefully the future we can change the trajectory of what's being projected because it's going to be devastating. We need to encourage public voices out there. We need to change the direction of what Alzheimer's and the related dementias may have on our community.
Thank you so much, Carlos. It's a very good reminder. Feel like it's been said over and over in the meeting, but it's just such a very important point. Thank you so much. Good reminder. Jerry, why don't you go ahead?
Sure, thank you. So I'm new to the committee, but a lot of things resonate, and I think it takes a village to move this topic forward. But one of the things I kind of was digesting is healthcare financing has to come as part of this things of the solution, and similarly in the pediatric world for ACEs, which is addressing adverse childhood experiences, was those screening and surveys were covered by Medicaid. I don't see something similar around dementia and how to get the providers more educated, but also that the screening itself is paid for in a meaningful way. And I also, if dementia, as all the evidence shows, the exponential growth that's going to hit California in terms of human lives as well as economic costs, are usually the best person to advocate for that is the California Surgeon General. Nadine Burke advocated for pediatrics and the pediatric screening. Have we as a committee really tried to solicit help and more support from the California Surgeon General? And I'm on the website right now. Her priorities does not include dementia. So it would be good, from my perspective, to include folks like her into the conversation early so that could be another person that advocates for dementia awareness and screening. Thank you.
Let's turn back to our public attendees one last time before we turn it over to the committee chairs to summarize what was heard today. Again, on the public side, if you would like to leave a comment, on your Zoom toolbar, you have a raised hand icon. Feel free to use that. If you're on phone, it would be *9. And of course, after this meeting, if you have a comment, feel free to write it to us in an email. Engage, engage@aging.ca.gov. Sorry, let me say that again. Our email address is engage, engage@aging.ca.gov. Wynn and Carlos, I think that we have no further comments from the public side.
Thank you, Carol. Yeah, just to address Dr. Jude's question about the ACE, the Dementia Care Aware is actually an attempt for us to to have that with the cognitive screening that has been implemented for the last few years. And we've they've received funding. I keep saying we because I was part of this committee to develop these programs and then sharing them to everyone, to primary care physicians and other folks that can help with screening and management, as you heard from Andrew today. So there are those efforts, and I actually started with Dr. Burks when she was still the Surgeon General to kind of help push this. So not that so there's been a lot of efforts. Susan and I have been in the task force, and it's just amazing to see all this progress to date from our recommendation to now the implementation of the different parts of it. So I highly encourage you to actually go to the website, the Alzheimer's recommendations, and then the MPA website to see what progress we've done so far. And obviously we will be sharing those with you in meetings like today as we have more updates. So we'll now review and finalize our recommendations for our secretary, and Carlos and I will guide this discussion and ensure everyone has an opportunity to provide input. Do the committee members have recommendations that like to elevate? I think one thing I'll start. One of the things that I said is perhaps have more presentation of the progress in the other types of dementia, not just Alzheimer's, frontotemporal Lewy body, so that people will know that these other dementias out there are something we all need to know about, and so that caregivers will also have a better understanding the difference of how to care for folks with these different types. Dr. Mobley.
Yeah, I want to just reflect on what Carlos and Barbara talked about, and would certainly want to support funding for dementia care, where I was part of the committee that sort of got that going. I saw a lot of promise in that. And I think it's even more of an urgency now because so not only do we have approved therapies, but we're likely to have more approved therapies. So if the need is great, and it is, and if the training is available, and it is, and if the value for training is considerable, and it is, then my question is, why are we seeing such low rates of screening? I think rather than simply, I would encourage us to ask for a really thoughtful analysis of why, if there's so much available, there's so little screening. And I would argue that's a research question. Maybe one needs to talk with physicians about why they're not doing it, or maybe ask families whether there is some problem in getting the screening. I just want to know why, if we have this resource, it's not being used effectively, because I think it's not only not okay now, it's going to be even more not okay when we have several approved therapies that are simply not being used. I mean, dementia care where could be a life-saving option for families and people with Alzheimer's disease. So I think this committee ought to recommend a very thoughtful, comprehensive set of questions regarding, if this is available, why is it not resulting in increased screening? Literally everybody over the age of 60 in California ought to be screened every year.
Can I add on to that? Because you brought up a good point, Dr. Mobley. I know some of my people that I associate with in the dementia space, especially the older ones, they're scared to get tested. And then there's the ones that don't know that there is availability to access to get these testings, these early diagnosis or detections. There's a lot of information, awareness on those subjects that can be kind of touchy. But I think we need to get it out there more so people can have that accessibility.
I agree, Carlos. And I mean, the fear that they have is almost certainly justified from the perspective they have. But the perspective they have may need to be further informed by what's really going on. So yes, there's a real reluctance to be diagnosed with it. And I could easily understand why that would be the case. They may lose privileges, they may have their license removed. There are all kinds of reasons why they might be afraid. But I think we need to know the reasons. And then I think we need to mitigate whatever is limiting their willingness to be screened. Part of it's education, but part of it may be legislation that says, we really need you, physicians, to basically screen every year. And we will audit that. We really want to make sure that we're capturing folks that need our help.
That's good. We need to write that down. And
I have a question. I have a question about that, Dr. Mobley. Do you think that with the work of Dementia Care Aware, they did any of that analysis? I'm just wondering if Anna Chodos might be able to kind of provide some insight into that as well.
Yeah, and I think
What I remember about it is that mostly the effort was focused on how should we screen. I think much of the effort was just trying to make sure that we really understood how to train PCPs to do the screening. If there was a lot of, I don't remember a lot of sort of inquiry as to why that could be difficult, although I'm sure it's difficult. I see it. I see the reasons myself for why that might be hard. So I'm not actually saying we should, just push screening. I'm saying we ought to ask the question, why, if it's available, it's not happening.
Okay.
Barbara.
I just want to build on this conversation by maybe another item we should include in the letter to the secretary is just, again, to provide guidance to Department of Healthcare Services to continue their efforts to help healthcare providers understand the dementia screening quality measure and to consider how we might, because it's right now, because this is where the state has the ability to put in equality measures related to the population of people who are dually eligible, for Medicare and Medicaid. But there are others that fall outside that bucket, and just how can we just continue to strengthen this quality measure, and helping the healthcare system in California understand it and embrace it.
I just have to wonder how much is just starting to normalize asking. People are afraid. There's a million metrics that we're having to already do and try to meet from a primary care perspective. And I don't think it's just normalized to ask. They're afraid to bring it up. They seem fine in the 20-minute visit, and maybe that's just the start. Do you have any concerns about your memory? Have you had any change in function?
And the mini cog and those other really simple to administer tests are not that difficult to do. I think we have to understand the context of the primary care visit, the return visit, which is really constrained by time. These poor folks are overwhelmed with all the things their institutions and their health systems are asking them to do. So one suggestion is let's find out if that is a real issue, and let's make sure that they're able to be rewarded, if you will, for doing their job.
I can promise you it is as a primary care doctor. Visits are tight, lots of things to do.
I think that's what Dementia Care Aware was touching, actually, that there are other members of the healthcare team that can help with screening. It normalized a lot of things, and the work with public health would take on Alzheimer's years ago, I believe. They came together at that time, and maybe we need to revisit that to reduce that stigma so that cognitive health is just health, right? And that's the whole message of Dementia Care Aware. I think it's, I know within our system, Janine, we had that efforts. We did share Dementia Care Aware as far as attendance. We can't really make people attend these training courses, but they're available out there. And I think all of us here in the committee or the public attendees know that they are out there and share them to all the people that you know, so that we have more people learning about the different resources that already exist. We don't have to reinvent the wheel. We don't have to start another program. They're all here. It's just sharing what we already have.
But if they're not being used, there's a reason or reasons for that, right? It's not like they don't have it. It's that it's not being used effectively. So my question has to do simply with, let's find out all the reasons that are restricting the use of screening, whatever they are, across the board, family, doctor, health system, whatever they are. Let's understand in a very thoughtful sort of research framework, critically asking, what is it that's missing here?
And I think there's some work in that, even before launching the dementia care, we are trying to address those things, but I think we should do a follow-up. I'm not sure who the group would be.
I wonder if Anna.
I think we could ask Anna, and I wish Jarman was still here. I think she is part of that group actually. So hopefully we can invite them back to our meeting this year.
Maybe that's a topic for a meeting, is basically dementia care aware, and kind of digging in to, or seeing where, what additional elements could be learned through research on why the screening tools are not being utilized.
Especially with us trying to elevate this, I think it's important for us to learn from the group themselves and get an update. Thank you, Dr. Mobley. Anyone else?
The comments saying thank you for including related dementia into the conversation to the answering session.
Yeah, I think that's a good, you're recognizing, including related dementia, because there's so many other dementias beyond just Alzheimer's. And we were talking about off record or off microphone earlier about that a lot of people, many people may be having mixed dementia. And like I personally see different symptoms with my dad that are associated with Lewy body or even frontal temporal dementia, and it's very confusing when medical professionals are telling me that, oh, it's just Alzheimer's dementia, and some of these symptoms are common, but could it be a mixed dementia that my dad is experiencing? Is he living with these symptoms? Why is he having a bad day? And those symptoms are exacerbated by certain triggers. And it's very confusing for me trying to figure this out and trying to convey it to the memory clinic that my dad attends. It's just hard to understand, and we need to recognize that there's just more than just Alzheimer's. Dr. Mobley, you have a
Well, I want to agree with you, Carlos, and I think it's important to say that we're not asking the PCPs to become neurologists. That's not their job. We're simply asking them to do the kind of screening and to raise the kind of red flag with their neurologist referral that helps you and your family and all the other families get a clearer idea about, is this Alzheimer's disease or is it not? It turns out it's a very large set of autopsy studies that look at how was this person diagnosed and what did they have on pathological examination. Virtually everybody 80 and above is actually has multiple pathologies in their brain. It may be Lewy bodies and Alzheimer's pathology. So bottom line is, if PCPs will just do the screening, then neurologists can help with that more sort of finessed evaluation and diagnosis.
Thank you, Dr. Mobley. I guess in chat there from Cindy Foltz, a Alzheimer's disease program would be happy to be part of the conversation as well. Anyone else? Comments?
Committee members, what else do we want to elevate? I just want to review a few things. Thank you, Brian. So another one that I think we had shared earlier is healthcare financing has to come as a solution, particularly for Alzheimer's and other related dementia, to pay for pre-screening and what else? I think we captured the rest.
Yeah. Well, I just want to say thank you for all of your time and thoughtful participation today. Each of us, all of you, play an important role in advancing this work.
Yeah, I want to echo that and thank you to our committee members, presenters, and staff for another productive meeting. We look forward to continuing our efforts and welcoming new members in 2026.
And with that, this meeting is adjourned. Have a wonderful rest of your day.
Thank you. Bye.
Thank you. See you on May 7th, next
Yeah.
meeting. And here is where you can find our resources on the Cal HHS, or California Health and Human Services Alzheimer's Disease and Related Conditions Advisory Committee webpage. The recording of this meeting, plus all the very interesting slides, very detailed slides, will be posted there. So feel free to go and grab them yourself. And as always, stay connected. Thank you.
Thank you.